Yes, my name's Michelle Batty, and I'm the manager of the European reference network that we call EUROGEN, which deals with rare urogenital diseases and complex conditions. But before we move to our speaker, I would just like to take a few minutes to introduce a little bit about the European reference networks. So there are 24 reference networks which cover different medical fields, and they were created by the European Commission in 2017. They're virtual networks of healthcare providers who all deal with patients with rare urogenital diseases and complex conditions. The aim for us as a network is really to deliver faster specialist evaluation, more equitable access to high quality diagnosis, treatment and care for those patients with a rare urorectogenital disease or a complex condition that requires highly specialised surgery. So some of our activities, briefly, within the network, we collaborate using a clinical patient management system, which is an IT tool developed by the European Commission for the ERNs, which allow us to conduct virtual MDT European level meetings between the specialist centres to give expert advice to any healthcare professional in the EU who would like it. We also collaborate on education and training, such as this webinar programme, and we also have a clinical exchange programme for short visits between our healthcare providers. And finally, we're also working on a EUROGEN registry, which is very exciting, and we hope that the contributions from the various clinical teams will help to us to develop a baseline of the current clinical practices across Europe, across the disease areas that we cover. If you want to know more, please visit our website, and we collaborate with many of the scientific societies, and I should say that this isn't the end of the story today for IC. We're also having a mini series on this topic in collaboration with ESIC, and those will be featuring next year, so keep an eye on our webinar programme. And then that's enough about the reference network. Now over to our presenter this evening, which is Dick Janssen, who's a colleague of mine at the Department of Urology in Radboudumc University Medical Centre in Nijmegen in the Netherlands. And there he's focused on BPS IC related research, preclinical and clinical, and he also works as a consulting physician in a multidisciplinary bladder pain healthcare centre at the Andros clinics in Barn and Arnhem. So thanks ever so much, Dick, for giving us your expertise here this evening. And the webinar will focus on the best way to organise your clinic for BPS healthcare and how to approach your patients to obtain the very best results. So without further ado, I'm happy to give you the floor, Dick, and thank you so much.
I want to talk to you today about what the title says for itself, effective multidisciplinary bladder pain syndrome treatment or healthcare management. Let's see if I can. Yes, we'll be talking about 30 minutes, and there will be 50 minutes for questioning for Q&A. So let me know, just ask. Let's make it as interactive as possible. I have no conflicts of interest for this talk. So for the contact, I will talk about these items. And I want to start you just with like I already stated, I want to focus on this talk on really on healthcare organization. Why? Because guidelines are everywhere. They are very accessible, but the guidelines often do not tell you anything on how you should approach your patients, how you should organize your healthcare with your patients. And I thought that would be a different approach for today. And I hope you will learn from it and also have an interactive discussion afterwards to see how, and we're really curious how everyone else does it, of course. As a kind of introduction, what I see as major bottlenecks in clinical practice, I think there's a lot to do and to improve on awareness. There's limited awareness often with the GPs, the urologists, even also the gynecologists or other specialists about bladder pain syndrome. In the GP, especially first line, there's also a lot of confusion with recurrent urinary tract infections. With the gynecologist, sometimes it's confusion with endometriosis. But especially the recurrent urinary tract infections, I see as the major delay for general practitioners to send patients or refer patients to a urologist or a specialized clinic. Also, what I see in the Netherlands, but also abroad, is that there's often a lack of specialized or centralized healthcare organization for chronic pelvic pain. So that sometimes lead to referral problems. And I think the ERN network is an example on how you could combat these problems by looking internationally, looking at digital solutions to these types of problems. As a note of fact to prescribe, to demonstrate these problems, there's a delay in most countries that is on average 5 to 8 years before a patient receives their correct diagnosis and treatment. This is a very long time and many missed opportunities to combat this problem. So, and this summarizes all the things above that can be improved already. So if I can improve anything, is that patients get to the right place at the earliest time as possible, because that gives us a better job at fixing the problems. About terminology, well, in my opinion, there's a lot of talk about terminology, and in my opinion, it changes. All the changes just confuses. I'll be using bladder pain syndrome in this presentation, but again, international differences in terminology and everything, it just confuses a lot. I'd rather talk about the symptomology and the problems and the way to fix the problems. And I think everyone should be aware that by far majority, bladder pain syndrome is an inflammatory bladder condition. Not in all, but in the far majority it is. And there's different subtyping. I will use the ESIC subtype, I think, because it gives the most clarifying terminology as we can use and for stratification. I'll be coming back to that later on. Symptom burden, very high. So an average fast pain score is, if you look at a scale of 1 to 10, it's about 6.5. Quality of life is often comparable to severe rheumatic arthritis or Crohn's disease. What we often see that there's a correlation with autoimmune diseases. We see a lot of comorbidity with Sjögren, lichen sclerosis, Crohn's disease, and so on. But also there's a high correlation with atopic diseases or allergies, eczema, asthma, other types of intolerances, but also very well, sometimes sensitivities for drug allergies or toxicities. And there is also a correlation with many functional disorders, IBS, fibromyalgia, chronic fatigue syndrome, migraine, and so on. So I think this is something to take into account, that there's sometimes other diseases that are correlated with bladder pain syndrome. So we need a holistic approach. And I think it's very important that you say, okay, bladder pain syndrome is not just a bladder condition. It starts often with a bladder condition, but there's also a lot of secondary problems that will be necessary to treat to get a better outcome. And stratification of phenotype can help you organize, I think, the best healthcare team to help an individual patient. I'll be talking about organ confined subtyping, pelvic confined subtyping, and systemic or functionalities type of stratification, because these all deserve separate attention. When we're talking about organ confined subtyping, I will just look at the bladder symptom burden. Is there mild or no pain, or is there very severe pain, frequency, nocturia? This all comes in a huge scale, sometimes very mild, but there's every step in between to severe pain, frequency, and nocturia. We'll also look at this for the majority, it's an inflammatory condition. So I will look at the degree of inflammation, and these also come with relatively very normal bladders to patients who are just bladder crippled because of such a severe amount of inflammatory disease within their bladder wall. But I think it's very important to know which stadium your patient in, which subtype of bladder pain syndrome this patient has, and to see what you can do with your treatments. Also very typical, and that's something that you learn along the way when you treat your patients. Also assess if they are good responders to therapy or bad responders to therapy. That also is quite, I think, in my approach, relevant to see what the outcomes are of your treatment successes or also your failures as well. To get more clarity on this, I think I always ask in detail what are the main symptoms, of course, when did they start? Often starts with an incident, a urinary tract infection, some kind of pelvic surgery, but it could be very varied on what triggers it. And then what we think, as far as we know, there's no certainties that the immune system is triggered to attack the bladder wall. There's no virus or bacteria or any type that has been found yet, but if you take a biopsy, there will be a huge influx of immune cells within the bladder wall. With most type of autoimmune-like diseases, I will not say for sure that BPS is an autoimmune disease because it has characteristics, but also non-characteristics. But most autoimmune diseases or allergies or atopic diseases start with an incident often, being it a food allergy, eczema, or something like that. Very important to ask if how the progression is. Is it relatively stable or is it progressing over the years? What are triggers? Are there activities, food items, diet that trigger the symptoms? And what can also help, of course, is to use validated questionnaires like the ICSI, PI, to evaluate your patients systemically and also for follow-up as well. I think it's a very useful question when my patient really in detail ask when the pain occurs. Is it during filling? If so, then it's often a bladder-related inflammatory problem. If it's during voiding, it could also be bladder-related, but often also pelvic floor, urethra is involved, and pain after voiding. And that's often, in my opinion, quite typical for pelvic floor problems that are secondary to the bladder pain syndrome. Problems. What often helps also for pain, of course, to objectify it, to perform a VAS pain score, to see how your treatment effects are within time. Objectify storage problems, use a voiding diary, also voiding problems, use flow residue measurements, uroflowmetry, and always I recommend in every patient perform cystoscopy, and if needed, a biopsy. There are clear assay classifications for this, and especially for cystoscopy, I always take care to also properly assess the urethra and the bladder neck region for inflammation. If there's redness in mid-urethral, there's often signs of pelvic floor dysfunction. So you can also see, okay, in addition to your pelvic floor physiotherapy evaluation, of physiotherapist evaluation, I think you can have some secondary signs also for related pelvic floor dysfunction problems during your cystoscopy. Then, as the criteria, I think these are vital. I think since we've implemented them in most guidelines, I think with the cystoscopy, I think taking care of our bladder patient and stratifying them has become much more, much improved. We have type 1, which has no visible abnormalities. Often also when you use a biopsy, there's no abnormalities in there. In my clinic, but again, I have a referral clinic, so I don't see many type 1s. But on occasionally, in 1 or 5 or so, I do see one, and then I focus mostly, okay, what could be the other problems associated, or maybe also to see if there may be other related problems like prior pelvic surgery, meshes, and so on that might cause these types of complaints. Type 2, of course, we have the glomerations and vascular abnormalities, often redness of the mucosal areas. It's also often segmented, so it's not often complete bladder, but also segments with these patterns with glomerations and vascular abnormalities like these tordated vessels that you can see here in the bottom picture. And there is type 3, which is the 100 lesion type. Much more incentive is there now currently to maybe differentiate type 3 and make it a separate disease, because the 100 lesion is really a unique disease characteristic. It's not found in any other disease, and I tend to think that's a good idea. But for healthcare, it's really there's some advantage from if you have honor lesions that for coagulation or ablation of your honor lesions. So there's some treatments that are specific for type 3 patients that are limited available for the other type. Of note, female to male ratio is 9:1, so it's often more affected by females, but there are definitely male patients that have Bardet-Biedl syndrome, also honor lesion type disease. And if you look at it, type 2 and type 3 have, well, everyone has severe symptoms, but type 3 overall has a little bit more bladder-related symptoms compared to the other subtypes. Regarding to pain, smaller capacities, and so on, because it's so that's something to be aware of. But again, it doesn't rule out that patient type 2 has mild symptoms, because they can also be severely affected as well. Local phenotyping guidelines often fully focus on bladder pain syndrome, but don't forget there are other inflammatory conditions out there, and you need to be aware of that as well. So you can have, of course, chronic radiation-induced cystitis, which is not so difficult to detect because patients will have a prior history of radiation. It can also be chemotherapy-induced cystitis as well, ketamine-induced cystitis, eosinophilic cystitis, cystitis cystica, but also other ones, like we always afraid of carcinoma in situ. Again, it's quite rare. But if you have a 50-year-old or a 60-year-old smoker, then always consider that it might be carcinoma in situ, because it can be really difficult to differentiate from bladder pain syndrome, type 2 and type 3 even. And also urinary tract infections, and so can also give quite a hemorrhage type of cystoscopy image. Forensically, they have, of course, bladder pain syndrome is still an exclusion diagnosis, so you have to rule out confusable diseases. ESIC has made an entire table. Joop van der Merwe designed this table, but I do always want to inform everyone that having a confusable disease does not always rule out bladder pain syndrome. Patients with bladder pain syndrome often have urinary tract infections because they have, I will come back to that later. Often there is pelvic floor abnormalities, which are secondary to bladder pain syndrome. So a confusable disease is worthwhile to look for. And it's the same as OAB. Yeah, a lot of patients with BPS also have some sort of overactivity of the bladder. But note down, it doesn't exclude bladder pain syndrome. For organ confined subtyping, I've just talked about recurrent urinary tract infections, and I think this is something really underestimated. Also in guidelines, there's hardly any mention about urinary tract infections, but bladder pain syndrome patients have an increased risk for urinary tract infections. We are currently investigating this with our patient association, the Dutch Patient Association for Bladder Pain Syndrome, ICP it's called, with a patient survey, and we're also looking at the 2 clinics where I work, also to do an inventory on how many patients with subtyping are also affected by urinary tract infections, and why are they overall more have this increased risk. Well, mostly they are women, often postmenopausal, which on average gives an increased risk of urinary tract infections. But due to the bladder pain syndrome, they have an impaired mucosal barrier, and it also is impaired for protection against bacteria. Due to overactive pelvic floor function, so pelvic floor musculature, there's also often voiding dysfunction, incomplete emptying, those kind of things, which can also leave them a bit more prone for getting urinary tract infections. And I always say to everyone, having a bacterial urinary tract infection on top of bladder pain syndrome is like oil on fire and really severely inhibits BPS treatment results. So there's a key focus in our clinic to prevent and assertively treat urinary tract infections in our BPS patients to get better results. Going forward into more pelvic confined subtyping, Well, other local pelvic abnormalities can increase bladder pain syndrome related symptoms. And if these are not properly treated, they will also reduce the efficacy of our bladder pain syndrome treatments. Therefore, I think all of these, the gynecological tract, the gastroenterology tract should be properly investigated. Pelvic floor is the same thing, to see if there are other correlated comorbidities. So, and depending on the amount of comorbidities there are locally in the pelvic area, the more things we need to pull out of our treatment scheme, the more ideas, more concepts, more treatments to target these type of problems to get an effective treatment going on. Again, as an example, these are all different pelvic floor related or pelvic area related problems that can induce chronic pelvic pain. Bladder pain syndrome is one of them. But all these things are often related. There's an increased irritable bowel syndrome, chronic anal pain, hemorrhoids, anal fissures, pelvic floor musculature pain, endometriosis from a gynecological point of view, lichen sclerosis, all those kind of things they can add to this chronic pelvic pain, which is often just as dominant in the symptomology and the quality of life impairment than the inflammatory bladder condition itself. So for pelvic confined subtyping, I would always advise to have a pelvic floor physiotherapy assessment. In my clinic, every patient has seen by an intake with pelvic floor physiotherapy, because there's overactivity of the pelvic floor is often, and trigger points are often present in bladder pain syndrome patients. And these can often be associated with desirous of pain during voiding and also prolonged pain after voiding. Just talked a little bit about that previously. From a gynecological assessment, we also have a gynecologist in our team. If there's signs of dyspareunia, mucosal atrophy, postmenopausal, for instance, lichen sclerosis, I see often in my patients, but also vulvar infections and so due to antibiotic uses and so on, endometriosis, or even presence of an IUD, they can also trigger the chronic pelvic pain type of complaints and make the bladder pain syndrome problems worse. So assess them, treat them, or if and refer to your gynecologist if there is any signs of this. For your bowel function assessment, signs of IBS, constipation, anal fissures, hemorrhoids, we just talked about that. And I think it's also important for looking at a neurological point of view, if there's already signs of neural sensitization, especially when patients don't tolerate tight or clothing and so on, or even the skin is already tender and painful on touch. Those are signs that sensitization processes and our neural sensitization is really present, which sometimes make your treatment efficacy evaluation a bit more tricky, because you have to combat this as well, and to medication there's a lot of treatments, but again also make sure that sometimes when there's a neural inflammation, neural sensitization, that sometimes the objectivity of treatment effect becomes a little bit more clouded, more unclear, because it can be so persistent. Then I will say, okay, then we've done the pelvic floor evaluation, but also look at systemic subtyping. So assess if there's presence of functional symptoms, fibromyalgia, chronic fatigue syndrome, migraine, sleeping disorders. Sleeping disorders were reported by the Dutch Patient Association in a large patient survey as being the most dominant impairment in quality of life. So sleeping problems. So it's something to really pay attention to. Nocturia, sleeping problems is really of high impact of your quality of life when you have bladder pain syndrome. Also really assess if there's perhaps other immune disorders, signs of autoimmune diseases, atopic diseases, allergies, and so on. Might also guide you a bit in your treatment options. And in my experiences, people have an active autoimmune disease like Sjögren and so, and they have a relapse or of like a Sjögren or bacteria. Then it's often also coincides with more bladder symptoms as well. So any type of activation of your immune system, also via another disease, can also affect your treatment for bladder pain syndrome. So also make sure these people are in knowledge that you are having a patient that you treat for bladder pain syndrome, and that they should be aware of this as well. Especially with psychological problems, there's often depression, anxiety, burnout correlated with bladder pain syndrome, but also for the anxiety of getting more pain or getting a painful episode severely impacts, even if you do correct treatment and even if your treatment is working, but anxiety for getting a new episode of pain can be very limiting in the quality of life of the patient. And you can do something about this. I will come back to that later on as well. Always ask if there's a need for sexual counseling. Often there's dyspareunia, and we as physicians always often focus on the biological problems and those kind of things. And so if we fix the bladder pain syndrome and the pelvic floor, then sexuality will come afterwards and so on. But it's very important. It's also considered by the patient survey that we've done in the Netherlands with the patient association as for every type of age group, they still find it important that sexual function is still an important function in their quality of life. So ask if there's need for sexual counseling. Then I always assess, okay, what's the really functional social impairments? Are there work, financial problems due to their disease? Is there social isolation? Do these patients have a support network, a relationship? Is there understanding in their network, in their environment, in their family, and so on? I think that's really important because those things are often one of the main problems that patients will have, that we become socially isolated, they get work problems, and there's often a lack of understanding within their social environment. So sometimes really helping them with this is very, very important. I've put them all in sort of a cascade because this is what I often think is happening to my bladder pain syndrome patients. They start with bladder inflammation, but then they get this negative cascading spiral. Of course, it creates pain, sensitization problems, lower urinary tract dysfunction, pelvic floor dysfunction, sexual dysfunction, and then there come also the sleeping disorders, psychological dysfunction, social dysfunction, and eventually an impaired quality of life. If you do a proper inventarization of these types of problems, you will probably also can imagine who will be able to help you with these types of problems. And in my opinion, is that this inventory or again, this inventarization or stratification or phenotyping can really help you organize the best healthcare team to help an individual patient. There is a U-point classification system, which can be very helpful in getting a proper evaluation done to see, okay, which people in my healthcare network should I implement to help this patient. I said before, treatment I think should be an holistic approach. So we look at all the things that are going on that have an effect on their quality of life with bladder pain syndrome. And my personal philosophy will be that a good stratification guides you towards the most appropriate therapies and healthcare team. In my experience, also the best treatment results will get when you, well, I say you have a negative spiral that will affect your bladder pain syndrome patients, and it's best broken when you break it on multiple levels. So the best way upwards is by getting as many items that impact the quality of life of this patient treated. So the more fitted the healthcare team, the more success I think we can obtain in getting these patients out of this negative spiral. And sometimes one thing at a time is not enough to break them from this spiral. I think as general considerations for implementing your treatment, well, sadly, therapy responses differ. So it's really not one size fits all. Responses are poorly predictable, in my opinion. So overall efficacy of a treatment, side effects, toxicity can be very different in patients. I have people on amitriptyline that fare very, very well, and patients that don't tolerate it at all. Same goes sometimes for bladder installations, for pentazone polysulfate. All treatments that we offer even pelvic floor physiotherapy responses can be poorly predictable, but also tolerance for these types of treatments can be very much. So it's really is a trial and error approach, and that means that I'll come back to the data that you also have to make sure that if it's trial and error approach, that you also rule out patient therapies that don't work. So make sure to implement efficient treatment evaluation schedules and make them as short as possible. So if you try a new drug like a beta-3 agonist, or here you can, in my opinion, you can evaluate that in 2 weeks, not in 3 months. In 2 weeks, if they don't respond, then stop it, try something else. So make sure also with PTNS or other things, try to say, okay, which is the minimum amount of evaluation that I need to assess if the treatment does not work, and then you can stop it and prevent unnecessary long treatments that are not effective. I think it's therefore also, if you take this approach, it's really important to invest in patient education. No, they should become a little bit clinical experts themselves, but also expectation management. So don't give too much false hope. Say, okay, we're going to try this. We know it doesn't work in everyone, but it's worthwhile investigating if it works in you, and if not, then we keep on searching. And I think that gives the proper mindset for effective treatment and trying different treatments without getting too much disappointment from a patient. If you say, okay, we're going to try this and it works in everyone, and we're going to help you so much, it's a recipe for failure, because they cling to this as their golden tickets to out of their problems, and it's often is not. So expectation management is really important in our patients groups. Some general advices, just some advices. I always say, I always be pragmatic. Suggest the best treatments that in your experience work, and also according to guidelines, but also consider the patient wishes and their profile. It's a two-way street that should be with any type of treatment, but also sometimes people do not want some type of treatments. Sometimes they don't want intravesical therapies because they don't want catheterization. All those kind of things so we really have to take into consideration what the patient wants, and especially also does not want for treatment. And always reflect if your healthcare network is adequate enough to adequately treat the patient. I think you should all have some self-reflection as well as treatment. So, okay, am I the best person, and do I have the best healthcare team to look out for this patient? And if I think, well, I'm not so, or I know other specialists that maybe can additionally help, then I refer to these specialists myself. I also refer a lot to other specialists, for second opinions, pain clinics, and so on, to help me get the best results in our patients. That goes also with point 5. Which I think is really important. I see a lot of patients coming into my clinic, and they went to the urologist and they said, well, I cannot help you anymore. And then they sent them back to the GP. The GP is not sufficiently educated and to help these types of problems. A patient with bladder pain syndrome often needs a healthcare coordinator. So it really is up to the pain specialist to take up this role and see, okay, who in my network and can I approach, can I contact to help this patient get better healthcare and better results. And I think just referring to a GP is, if I don't know what to do anymore with a patient, I refer him to someone who I think can help this patient. So I think everyone should take that responsibility also to see, okay, reflect to yourself, see if you can provide the optimal treatment. If not, refer to a center or a clinic or someone else that might be additionally helping, be able to help this patient. Going back to advice number 3, be understanding. It goes also with what I just talked about. Most patients that I have had years of frustrating experiences with healthcare providers, with misdiagnosis, insufficient treatments, and they sometimes carry, what do we say in Dutch, they carry their soul under their arm, which just means that sometimes they're really disappointed in healthcare providers. And be understanding that they often are misdiagnosed, and they've often been carrying around with their problems for 5 years or more to get a proper diagnosis. So invest a little bit in trust and give them attention and some understanding that this is something that they had to deal with. Also to help them get more exposure, awareness, and so on, notify your patients about patient associations. They can really help guide patients with not only because there's a lot of people there with bladder pain syndrome that can help from their experience, but also for general information, referrals, and so on. So they can actually help a patient a lot deal with their chronic disease, chronic condition. For an individual treatment approach, I often use at the beginning two approaches. For the patients who, I often see two types of profiles. Patients who come in, carrying their sore on their arm, years of complaints, they really are in need of a win. With these patients, I treat aggressively. I start multiple treatments to really break the negative cycle that we just talked about. And then afterwards, if they get to what I would call the ceiling, okay, we've come, it's gone better with their symptoms and so on, and now we've sort of after a while reached the ceiling of, okay, this is the best possible outcome that we get in the short term. Then I'll start selectively decrease treatments to find a sort of a basement level. Other patients who come in and often they have some milder complaints, they are more cautious, and then I use a more stepped up approach until we reach that same ceiling. It can take a little bit longer, but the evaluation of your treatment effect become more selective. If you start many treatments at the same time, it can be a bit confusing how different individual treatments affect a patient. But again, I think that's secondary to, we need sometimes the patients that have been having these complaints for years, that they really need a boost in their disease management. So that's why I still use often in the first profile a multiple treatment scheme. I sort of divide it in treatment phases. I use sort of 3 treatment phases. At the startup, we can take 3 to 11 months. And then I try to reach the best outcome possible, reaching the ceiling of what can we do to help the patient's problems. And I do that with multiple modality treatment with our team. And it's also very important to properly evaluate your treatment effects. I think it's noted down after this startup phase, it's really to note down which patients were most effective in this individual patient. I think it's also really important to do regular cystoscopies, especially when you're targeting bladder, the inflammatory component of the bladder. Use regular follow-up cystoscopies, especially when the sensitization, pelvic floor problems, other type of chronic pelvic pain related problems. It's sometimes can be really a win that when overall when there's also improvement on cystoscopy with your treatments. And often when I say if it goes better with the patient, then I often see it most likely within cystoscopy that their inflammation has decreased. But sometimes if the patient doesn't show any improvement of symptoms, I can still sometimes see improvement on cystoscopy, but then that means that the sensitization problems, pelvic floor problems, and all the other related chronic pelvic pain type of problems have not been sufficiently treated at that moment. So regular cystoscopies for follow-up is, I think, really important. Then I come into sort of maintenance, the balancing phase, which is to assess the minimal therapy required to obtain stability, long-term stability. And I always say, okay, it's very nice for a patient after 5 years of symptoms and very many complaints to have at least half a year stability. So don't switch too much in therapies and treatments, and don't cut away too much of the treatments. Stability is something to be appreciated in a patient with chronic pains like symptoms like this. So carefully trim your therapies. That's my suggestion. And then there's also what can happen. It's a chronic disease. You can have relapses. So based on what you've assessed as what were the most effective treatments used in the patient, make an emergency plan for relapses. And always say to the patient, if you have an acute relapse, don't wait too long, because the longer they wait, the more severe the relapse, the harder it takes to get back again to that maintenance balancing stage. So here is, for example, a 50-year female with bladder pain syndrome subtype 3. For focus Janssen, this is the multimodality treatment. So the patient had bladder inflammation, had 100 lesions, of course. We started her on gag therapy, but there's also other options, of course. For her pain treatment, we started with amitriptyline, a tricyclic antidepressant, and also PTNS stents. This latter has limited evidence, but for pain, but still in the Dutch guideline, it's recommended. The urgenecturia, we have a beta-3 agonist started, and PTNS treatment. And the PTNS treatment and the TENS treatment, you can also put on a pain setting. You have an urgency setting and a chronic pain setting. So you can mobilize these two types of stimulation. The pelvic floor physiotherapist went to work on mobilizing her overactive pelvic floor. We did urinary tract infection prevention with Demonos that was sufficient at this moment. She had pain education with a psychologist. You don't need a psychologist for pain education, but there are programs for this to have them be more aware about how pain works. The gynecologist started local hormones for vaginal atrophy, and we suggested with a dietitian better patient-related elimination diet. So it's quite a lot of therapies, but they work all on different angles to help this patient get into a better form and function. Because I'm talking a bit long, excuse me. If the pain is not responding to treatments, reassess what's the most likely cause. You do recystoscopy, urine sediment, urine culture. Are there alternative treatments available at your center? If not, referral, like a pain center, to the anesthesiologist. And as last resort, there's pain rehabilitation centers in the Netherlands within, and I think they're across Europe as well. That can also help if you cannot find any, if your pain management is not adequate enough, even though you tried everything. If inflammation is not responding to treatments, reassess the cystoscopy, again, urine sediment culture. Be aware of, let's also try in doubt cytology or biopsy. If alternative treatments are available at your center, implement them. If there are severe refractory, inflammation, then refer to a rheumatologist or immunologist. This is not often done within the Netherlands or in Europe, but there's a lot of times this step is skipped and patient will get a cystectomy. And I will say, well, there are some things that we can try before we remove that bladder. So with immune suppressant and so on. So try to find out with your rheumatologist or immunologist if they are prone to help you be that step just before the cystectomy, which is really the last resort in my opinion. So the take-home messages, and sorry for a bit of the extended presentation time, but as a take-home, multidisciplinary approach is, I think, key to effectively treat your pain syndrome patients. Centralization of BPS healthcare can help. ERN can help, so use it. We should use it more. Remission of bladder pain syndrome, including type 2 and 3, is really possible. So don't think that these are lost causes. Remission is really, really possible. So we should always strive for it. We do not always obtain it, but we can strive for it, and we can get this in a reasonable percentage of patients. We can get to this stage. For targeted treatment, this can really help you just change the quality of life of your patients. And it's not a one-size-fits-all. Stratify your patients. And as a last message, there will always be a percent of patients who, despite all the treatments that you give, all your best efforts, will still have a considerable symptom burden. But in my experience with a multidisciplinary approach, they will always, almost always achieve a better level of function and quality of life, and you can help them, guide them through with their chronic condition. So I thank you very much for listening, and I hope there's questions, of course. Thanks.
And you can now type in your questions via the question button. We will just await a few minutes.
Also, let me know if you disagree with anything that I say. Yeah? So. Not all at once. I have to.
Dick has a question from Mariangela. Can you see it?
Questions. Oh yeah, I will separate the box.
Great.
Hold on for a second. Let me just separate the box from my field and make it a bit larger because it's very small digits. The use of cranberry extract is always not indicated. Some patients use it to prevent UTI and they are very happy. I always suggest to use Demonose. Why? Because cranberries, well, we use cranberries mostly to because it contains Demonose. And in balance pain syndrome patients, cranberry juice can be very acidic and actually increase their problems. If they're not very affected by diets on the symptoms, then cranberry juice is fine. But Demonose is not acidic, and it's the reason why we use cranberry substances for the majority of indications. So I would always recommend our patients to use Demonose for prevention. Yeah, and it's about 1,500 to 2,000 milligrams, I think, that you use as a daily doses. Yeah. Other questions? I must say I haven't seen many bladder pain syndrome ERN related cases coming up in for people I would like to see it more. So to see it using the ERN network for clinical advice on different cases. And I'm also to blame myself because I could also do this more. So I think with the whole ERN, I think it's a mindset that we say, okay, there's a whole network of specialists available through the ERN network. So,
Dick, we've got another question from Frank Martens.
Yeah. Oh, Frank. Hi, Frank. Let me see if I can find it. I cannot see the question. I don't know why. Oh yeah. Which drug for anticholinergic drug is better? Tolterodine, Vesiterdine, Sulfenacine. I have no preference at all, actually, for bladder pain syndrome patients. What I do recommend is try at least two, if there's for the urgency. And proper evaluation time. I just use a 2-week evaluation for each separate one. So what I often do if patients have much urgency and so on, complaints, which many people have, I will do prescribe 2 weeks of Mirabegol, 2 weeks of anticholinergic 1, and 2 weeks of anticholinergic 2, and say, okay, if you have one and you tolerate it very well, then continue with it. If you don't, stop it. Use wait 2 days and then start the next one. And then you have sort of in 6 weeks you can evaluate all the drug therapies for overactive for bladder overactivity very efficiently. So as to see if they work, yes or no.
Dick, are you able to see the question from Frank, or shall I read it out loud?
Yeah. It's very difficult for me to see who posted. Is it the phenotyping question?
Yes, exactly.
All right. Let me one now. Is the phenotyping with cystectomy? You showed UTI and ketamine bladder pictures of more like crying bladder. Often I see this alone, also or alone in patients with with previous treated Hunter lesions. I would define this kind of crying bladder not a typical UTI sign. No, actually I rarely distend bladders during office cystoscopy until I see a crying bladder. It's a crying bladder for me is just a sign that there is inflammation within the bladder wall, fragility of the small vessels, and rigidity of the bladder wall. So then when you extend it, there are cracks appearing, especially in the smaller vessels and in the bladder wall, which makes as a secondary sign that there's inflammation. But I rather not well, pill until I see this, because it creates more pain complaints. It makes the whole procedure more uncomfortable. You can do it under anesthesia, of course, but in office cystoscopy, I really would refrain from filling that much. I fill as little as possible until I can see the entire bladder wall. And sometimes when you say it's difficult to see, okay, if it's ketamine bladder, if it's CIS or any type of UTI or so. But you can also say, if you ask rigidly to see if there's ketamine abuse in the prehistory, if there is well, a positive urine sediment or urine culture, of course. So the main problem with subtype 2, ASIC subtype 2, it's very age specific. The vascular, you see these vascularizations, glomerations in many other types of conditions, which makes it difficult. So I say, when you're in doubt, take a biopsy, do cytology, for instance. But if it's a very clear picture, yeah, I think if it's a typical patient who doesn't have all these related prehistory type of things like ketamine abuse or so on, then you can quite easily diagnose a Hunter lesion when you see one. But if you have a very unapparent or different type of Hunter lesion, they say, well, what is this? I would always recommend to do a biopsy and a cytology.
Well, I think that's about it with the questions. Thank you everyone for joining, and of course, thank you Dick for the interesting talk. The webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel. I will send the links tomorrow, and all the links for the previous sessions are on our website, as are the details for forthcoming webinars. Finally, all of you who have attended today will receive a survey immediately after the session, and we would be very grateful if you could spend a few minutes filling it in, so you can help us improve further sessions. Thank you all very much, and have a nice evening.
Thank you. Bye-bye.